Well, good evening, colleagues and friends. I'm talking from out Nijmegen in the Netherlands. I'm doing this together with Philip Cornford, who's in Liverpool. We are obviously in our hometowns. Phil is Vice Chairman of the Prostate Cancer Guideline. I'm Chairman of the Bladder Cancer Invasive Guideline. And we're going to talk about recommendations from the EAU Guidelines, which are applicable during the COVID-19 pandemic. It's organized by the EAU and the European School of Urology. The schedule for this webinar is that first I'm going to talk about around 10 minutes about bladder cancer and testicular cancer. After that, Phil is going to talk about around 10 minutes about kidney cancer and prostate cancer. If we have questions to each other or questions afterwards, we can do that during the presentation or afterwards. We have some minutes about some general issues, and then you can ask questions through the web, which we will be trying to answer. There is a question portal. I have no conflicts of interests. So we were asked to think about some COVID issues which are important for urologists, and in this case, of course, especially for oncological urologists. And these are things that I am now encountering really in my daily practice for some months. There are, of course, limitations in the patient's outpatient contact. We have to stay around 1.5 meters aside, which is sometimes very difficult. So potential issues are new patients. I would like to see new patients and not only do that by telephone. If you have to do a physical exam, you've got a problem. I do, as a bladder cancer urologist, a lot of cystoscopies, ultrasounds, bladder installations. That, of course, is something that might be a problem if you have to stay 1.5 meters away from your patient. Prostate biopsies is a problem, so you can think of all these problems yourself. Then you have surgical issues. If you are around an operation with a surgical team, for sure that's not at 1.5 meter distance, unless you maybe do robot surgery. Then there are protective disposables such as masks, etc., which predominantly come from China, as I have learned now. And we have a shortage in the Netherlands, and I guess that's an issue in more countries. Then availability of OR time. There is a lot of life support equipment and personnel which has gone from the ORs to the intensive care wards, at least in my department. So we have drastically diminished the number of ORs that we are able to and allowed to fill. Then, of course, after the operation, what does a postoperative fever mean? The rule in my hospital now is that if a patient has fever beyond 48 hours after surgery, he is going to the COVID department to see whether he has COVID, yes or no. And obviously, some of these patients will have some fever. You will have an increased infection risk, so there are a lot of consequences in daily practice working in the current COVID era. So that sometimes is a nasty problem. What are we talking about? These are the updates of yesterday by the Johns Hopkins. You see the mortality rates per million inhabitants in Europe. You see that Belgium, unfortunately, is rising quite rapidly. Then the second and the third are Italy and Spain. That started, of course, very dramatically, but you have the impression that it's going down a little bit now. At least the increase is less. After that, you have France. We are below that, and in this figure, you can see that Germany, the rise is still relatively low, and that's again mortality per 1 million inhabitants. If you look at the absolute numbers, and these are again also of yesterday, you see that in Europe there are 3 or 4 countries which are above 20,000 people that died just due to corona. United States currently is, of course, very high with almost 60,000 deaths due to corona. And you see that we have already passed China. We are at number 9. And China, where the whole problem started, is at 4,500. And you see the rest is a little bit above that, and that's only the other countries. So what we have done within the EAU, there has been a Guidelines Office Rapid Reaction Group, GORG called, and we've looked at the guidelines that we have and tried to apply rules and recommendations to those guidelines in the current era. How does that work? We have defined some priorities, and as you can see here, there is a low priority, meaning that you can defer that what is in the guideline by around 6 months. If the clinical harm, progression or metastatic disease is very unlikely to happen within 6 months. Then you have intermediate priority if there is clinical harm expected within 3 to 4 months. You have high priority if clinical harm, which is progression, metastatic disease, anemia problems, or even cancer-related death, are likely to happen if you postpone this care more than 6 weeks. Then emergency is, of course, life-threatening situations, opioid-dependent pain, hematuria, things like that. And that's something you should do within around 24 hours. And you see in the right bottom, low, intermediate, high in emergency, which is more than 6 months, between less than 3, less than 6 weeks, and within 1 day. I'm going to talk about non-muscle invasive bladder cancer, invasive bladder cancer, upper urinary tract cancer, and testicular cancer. Let's start with non-muscle invasive bladder cancer. Diagnosis remains high priority, so that's something which is relatively easy with cystoscopy and a picture with cytology, so that is something that you shouldn't postpone. You should do that within around 6 weeks. If you then look at treatment of non-muscle invasive bladder cancer, that is, as you can imagine, depending on the risk category. So low priority, meaning that you can postpone that for 6 months if necessary, is a transurethral resection and installation in low-risk tumors. Then intermediate priority, something that should be done within 3 months, is a resection and installation in intermediate risk patients and radical cystectomy in high risk or unresponsive patients. You know that for invasive bladder cancer, the time that you have until you have to do cystectomy is also around 3 months. So for high risk or unresponsive non-muscle invasive bladder cancer, also 3 months is considered to be a realistic option. Then high priority is non-radical treatment, so installation therapy in high-risk patients. You shouldn't postpone that for a long time. You should start with, for example, BCG within a few weeks. And obviously emergency is patients with, for example, clot retention or hematuria. That's something that you have to try to treat within 24 hours. And if you look at follow-up of non-muscle invasive bladder cancer, that also depends on the risk category. Again, low priority is in low-risk patients. You can postpone a outpatient cystoscopy at least for 6 months. The guideline says already 3 months, but in this case, 6 months is acceptable. Intermediate priority is in intermediate risk patients, so they should do probably the first cystoscopy after 3 months. And the high priority remains high-risk patients or patients with hematuria. And obviously, again, emergency is patients that have macroscopic hematuria or clots. Then I think you have to do care as soon as possible. Whether that should be done within 24 hours, I don't know, but certainly not delay that for weeks. Upper urinary tract cancer. Diagnosis by ureteronoscopy is of intermediate priority, but imaging, where you probably can see a lot already with a very decent sensitivity and specificity, remains a high priority. Then treatment of upper tract urothelial cancer. The low priority is a single post-op installation after you, for example, have done a nephrectomy for a pilum tumor. Although that is a grade A recommendation or a high-level recommendation and guideline, that is something that you could postpone in the COVID area for 6 months. And also perioperative chemotherapy in invasive upper tract urothelial cancer. The benefit is, of course, not as proven as in bladder cancer. And we all know that chemotherapy can diminish your immune system. It can decrease your immune system. So that might be a problem. So also that might be postponed. Intermediate priority is kidney sparing in low-risk tumors. That probably should not wait too long because those tumors will grow and will cause problems. But if you can do that within 3 months, that's fine. And systemic treatment in metastatic disease. I think that is in the higher range of intermediate priority. I wouldn't wait for 3 months with that. But again, that shouldn't be, that doesn't have to be done within weeks. High priority remains surgery in high-risk disease to prevent, of course, metastatic disease. And emergency is, again, symptomatic patients. So patients with pain or obstruction or hematuria. With regard to follow-up, after radical surgery, if everything is out, I think the priority is quite low. You can wait for several months to do, again, imaging. Intermediate priority is something that should be done in kidney-sparing treatments. And of course, you want to know whether there is no recurrence. And that means that you would have to do follow-up within around 3 months. High priority is after systemic treatment. Those patients are obviously at a high risk of recurrence, so you shouldn't wait too long. And again, in case of complaints, there is an emergency indication to do something with those patients. If you look at muscle invasive bladder cancer, the diagnosis remains high priority, which is TOR and imaging. You should try to find a muscle invasive bladder cancer as soon as possible. The treatment in non-metastatic disease, which we have defined as low priority, is neoadjuvant chemotherapy in limited invasive bladder cancer, so T2 to T3 disease, and obviously also in trials, unfortunately, but still that's not considered a high priority. Intermediate priority is radical surgery or multimodality treatment. Like we already discussed in non-muscle invasive bladder cancer, you are more or less allowed to wait for around 3 months until you do surgery or multimodality treatment in invasive bladder cancer, so that didn't change a lot. High priority is neoadjuvant chemotherapy or adjuvant chemotherapy in very advanced disease, so T3 or T4 disease. That really is a high priority. And if you do that, then consider supportive measurements like G-CSF. That will boost your immune system, so that might be something to consider. And again, emergency is symptomatic patients, acute renal failure, hematuria, pain. I think that makes sense to do that as soon as possible. Treatment of metastatic disease, intermediate priority is chemotherapy based on disease burden, which means if you have a very low disease burden, you might have a little bit more time than if you have a higher disease burden. I would consider that again in the higher end in intermediate priority, because to wait 3 months, I think that's a bit much, but still you have some time. And again, if you're going to treat with chemotherapy, consider supportive measurements like G-CSF. Same goes for immunotherapy, first or second line. So all systemic treatments are intermediate priority. Again, my personal feeling would be that it's in the higher end of intermediate priority. And something we don't see a lot, but which is coming more and more popular the last few years, is surgery in true oligometastatic disease. So those patients that have only 1 or 2 metastatic lesions, you can still do surgery on those patients. And again, then there is a term of around 3 months, which seems to be acceptable. However, if you have symptomatic patients with metastatic disease, then treatment is a high priority. I think certainly you should try to start with those patients as soon as possible with chemotherapy or immunotherapy. There is a higher benefit of treatment. And if you give chemotherapy, you should again try to combine it with supportive measurements like G-CSF. Follow-up of the patients that had cystectomy is a relative low priority. You can postpone the first CT scan or first checkup for 3 to 6 months. Going to testicular cancer, you see that the only low priority with regard to the initial workup is a contralateral biopsy and sperm banking. What remains a high priority or even emergency is the primary diagnosis / initial treatment of testicular cancer. So ultrasound, physical examination, and laboratory investigations should be done as soon as possible. The same is orchiectomy. We should try to do that within a couple of days. And the same goes for imaging after orchiectomy to see whether it's metastatic disease. So the whole setup for patients with testicular cancer, the whole initial diagnostic schedule should be done as soon as possible. If you then have your diagnosis and you are considering additional treatment, then there is a low priority in case of active surveillance is offered according to the guideline, which sounds funny. So if there is no treatment, you can postpone the no treatment for around 6 months. So that's a bit funny, but anyway, what is a high priority? If you do offer and consider treatment according to the guideline, that is obviously something that you shouldn't wait too long. So for example, in stage 1 disease, in high-risk non-melanoma, if you want to give 1 course of BEP, you shouldn't wait for a long time. Then treatment of metastatic disease, high priority is adjuvant treatment in stage 2A seminoma, which probably means radiotherapy or chemotherapy, and adjuvant treatment in stage 2A or B, non-seminoma without markers. That's a small group. Usually those are patients that are supposed to have teratoma in the retroperitoneum. So in that case, probably adjuvant treatment means surgery. And again, that shouldn't be postponed too long. High priority means within around 6 weeks. The next 2 I made yellow because the retroperitoneal mass after to do a node dissection and a growing teratoma, which also means a node dissection. Personally, I think, of course, you shouldn't wait too long. But for example, a residual mass in a patient that has marker normalization, you have some time to wait until you do the surgery. I think within 6 months is a little bit rapid, but again, you shouldn't wait too long. What is emergency, meaning that you have to do that as soon as possible, is systemic treatment in case of a stage 2B or more seminomas, which means chemotherapy. And the same goes for treatment in stage 2 non-seminoma with markers, which probably also means chemotherapy. I think we all agree that if you're going to do that in these young people, which are, by the way, less in danger for COVID problems. So if you're going to treat these patients, you have to do that as soon as possible. And again, what is an emergency? If there's a life-threatening problem, brain metastasis, poor risk, I think those patients obviously need treatment as soon as possible. With regard to follow-up, and then the GORC group has specifically defined that delay is compared to the original appointment. So apparently this is some kind of add-on rule. For metastatic disease, you can see that it is mentioned in low and intermediate and high priority. And that makes sense. You have to use your common sense. And you can imagine that if you have a poor prognosis patient that had a good response on chemotherapy, you will be more reluctant to wait a long time with your follow-up than if you, for example, have a stage 2A patients with the seminoma who had chemotherapy with a good response. So again, metastatic disease after treatment or complete response really depends a bit on the initial situation, and for that you just have to use common sense. I think that will help you a lot. Intermediate and high priority is stage 1 seminoma on active surveillance or stage 1 non-seminoma on active surveillance. I think that's clear. If you do active surveillance, you shouldn't wait too long to find potential metastasis. What I was personally a little bit amazed about, that if you have a stage 1 seminoma that has had chemotherapy, then the chance of recurrence is much lower. So I would consider that more intermediate than high priority. But you can understand that active surveillance, of course, is a reason to be to look at the patients with more care than if you don't do that. And then again, emergency is symptoms, brain mets, obstruction, pain, etc. So these are actually the recommendations that I try to explain to you for bladder cancer, non-muscle invasive and muscle invasive, upper tract urothelial cancer, and testicular cancer.
Right, Fred, there is a question here about COVID testing and chest x-rays before radical cystectomy. So what would your view be about anybody really considering significant surgery or any surgery? What tests should we be doing?
Well, Philip, that has been changing in my hospital now for 3 to 4 weeks a few times. So initially we only did the PCR test. Then we did, and that takes, of course, a day. Then we did the CT of the thorax, which that result you have very rapidly. But apparently both sensitivity and specificity are not that good. Then we did both. And I just had a recommendation from my hospital an hour ago that we stop with CT scan and that we only do, if indicated, a PCR test in those patients that might have COVID and even not in those patients that are without any complaints. So for the time being, the CT scan, which might change again next week, I don't know. But for the time being, the CT scan has now been left for the initial diagnosis of patients.
Yeah, I mean, I think that
it
is changing rapidly. So we are still doing PCR testing and CT chest for patients who are going to have surgery. But it does change rapidly. People are doing something different, and I rather suspect that next week we will be doing something different again. There's no doubt that's true.
Yeah. You know, if patients have complaints, that's of course a whole different story. But in those patients not having complaints, I have now operated on a few patients that a few days later appear to have COVID. I hopefully didn't have it yet. At least I didn't have any complaints. But of course, it is a risk.
And there is data from China suggesting that if patients develop COVID after surgery, that significantly increases their risk of mortality from the COVID. Any experience?
Well, I have 3 now, and they all 3 did actually quite well.
Well, that's good. That is good to hear, because the Chinese said that there might be a 20% mortality rate for people in that situation, based
Well,
on a
apparently
series
I
of
had the other
35.
80%. They did well.
They did well. That's good. Second question, should we evaluate intermittent microscopic hematuria as a high priority situation during follow-up of non-muscle invasive bladder cancer?
No, I don't think so. And that obviously depends a little bit on the history of that patient. If those patients have had, for example, a small low-grade PTA tumor, then yes, you might have a recurrence, but that's obviously not high priority. I would even dare to do, I do in those patients sometimes active surveillance. The only reason to be a little bit more aggressive might be if patients are worried about the fact that they have hematuria. On the other hand, if you have a patient that has had PT1 grade 3 plus carcinoma in situ with hematuria, you're of course afraid that he has again a high-grade tumor. Then I would try to do it as soon as possible. So it really depends on the risk of the patients that you are following.
Okay. There's a question here about intravesical installations. There has been some suggestion that BCG might even be of benefit for people with COVID.
Yep.
What are your views about intravesical installation of BCG during the COVID crisis?
It's a very good question, Phil. BCG apparently gives what they call sustained immunity. So there is some kind of immune boost, which is thought to be a little bit protective against getting the coronavirus. And also, if you have it, you will have less symptoms. To be honest, we are doing in my hospital and together with Ashish Kamat in the US, we're doing a study where half of the patients get a subcutaneous BCG injection and the other half are getting placebo. I joined that trial. I've had a big spot on my arm, so I probably have had BCG. I haven't had complaints yet. Whether I've been infected, yes or no, I don't know. But there is some sense in thinking that BCG might be more or less protective. We're also looking at the Dutch Cancer Registry now, all those patients that have BCG for the last year, because that protective effect appears to be present for 6 to 12 months. We're looking at those patients that have had BCG the last year. Those are a few thousand. We're contacting them to see whether they had corona, whether they have been in contact with corona. So yes, there apparently is a reason to think that it is at least not bad to give BCG. Whether it really adds to the protective effect or a better course of the disease, of course, it's not proven yet, but there are some studies looking at that now.
Okay, right. Because of time, I'm going to switch and now talk through some the questions on prostate and kidney. There will be an opportunity to take that again at more questions at the end of this. If you want to add questions, please submit them. Fred will see them and screen anything that's imminent, and then anything we haven't discussed, we will discuss at the end. Okay, so I'm going to start with prostate cancer. And for prostate cancer, perhaps the first thing to say is that screening of asymptomatic men is definitely of a low priority. We know that screening incidents of 2 years to 4 years have been investigated. There isn't a lot of evidence for a big difference between that, and therefore asymptomatic men shouldn't be encouraged to have screening during the pandemic. The other thing that's fairly clear is that people with low risk of finding a cancer actually probably can wait safely. So if you've got a benign feeling prostate and a PSA of less than 10, then there is probably nothing very much to be gained by rushing to have an urgent biopsy. It is quite possible that there is a small focus of cancer at that patient, but we know that prostate cancer will progress slowly. And because that's true, then delaying until the incidence of COVID is lower will be safer for the patient. Now, many people are struggling with availability of MRI, and therefore a pre-biopsy MRI, again, is probably a low priority. Now, if you've got an abnormal feeling prostate, and if you've got a PSA over 10, then a short delay, anything up to 3 months, is probably acceptable. We know that repeating the PSA is recommended in many countries. And so on that basis, it wouldn't be unreasonable for a short delay, particularly during the peak of the pandemic, but that with time, those people are going to need investigation. And when we think about this, as capacity comes online, we'll need to think about treating those patients with the intermediate risk before we go on to treat the patients with the low risk. Clearly, patients with a grossly abnormal DRE or a PSA of over 30 and severe symptoms, they are at high risk, and they probably are best staged with scanning rather than a biopsy. And that may allow you to diagnose metastatic disease and avoid biopsy. You'll be aware that fecal carriage of COVID can continue after symptoms have resolved, and many of us are switching, if possible, away from transrectal to transperineal biopsy where that's available. As has always been the case, ureteric obstruction and impending spinal cord compression need to be treated urgently, and that hasn't changed because of the pandemic. But those people looking for curative treatment, in truth, active surveillance for low-risk disease has largely, during the pandemic, become active monitoring. Some of the best data for avoiding treatment in people with low-risk disease comes from trials using active monitoring, and repeat biopsy and repeat scan at this time can safely be delayed. It's also true that brachytherapy, the insertion of fiducial markers prior to radiotherapy, and the insertion of rectal spacers should be avoided at this point. Many patients with low-risk intermediate disease are now being considered for active surveillance, at least as a short-term measure, while the pandemic goes on, as it's safer to monitor them than to institute curative treatment. And in particular, robot-assisted lap radical prostatectomy has largely been postponed until the incidence of infection is lower. We can see that even for people with intermediate risk disease, repeated biopsies and dragging patients back to clinic for examination can be avoided for a 3 to 6 month period. And for patients who are going to have radiotherapy, again, to avoid them coming into contact with lots of other patients, many of them are being started on neoadjuvant androgen deprivation for up to 6 months in the hope that external beam radiotherapy can be initiated at a point when the number of COVID infections have decreased. Clearly, patients with locally advanced disease will need more rapid treatment, and largely at the moment they are being treated with immediate androgen deprivation and a plan for external beam radiotherapy. And for curative treatment, there are no emergencies. Nobody with locally confined prostate cancer needs to be treated within 24 hours. For follow-up, for those people who've had surgery and have a persistent PSA, then you should postpone PET imaging until after the pandemic is solved. if treatment seems necessary because of a rapidly doubling PSA, you might consider androgen deprivation, but you probably are not going to give them salvage radiotherapy until COVID is past. For those people who present with PSA relapse after local treatment, if you are part of the high-risk group with biochemical recurrence, as defined in the guidelines, then you might offer them salvage radiotherapy, but those patients with low-risk biochemical recurrence would be safely monitored, and we would really only offer androgen deprivation for PSA failure after radiotherapy in those people with a rapid doubling time of less than 12 months. For treatment of oligometastatic disease, the new standard of external beam radiotherapy for low volume disease has largely been abandoned during this pandemic. And that certainly could be delayed for several months without significant harm. Again, for people presenting with hormone-sensitive metastatic disease, the suggestion is that you are better to treat it with androgen deprivation plus enzalutamide or apalutamide, because they need less support than someone on steroids with abiraterone. And for people, we are trying to avoid docetaxel for metastatic hormone-sensitive prostate cancer at this stage because of the risks of myelosuppression. There clearly will be some people with progressive castrate-resistant prostate cancer who have no other option other than docetaxel or carboplatin, and they might, if they are going to consider that, then you want GCSF as a way of supporting it. And clearly, people with bone pain may still gain benefit from a single fraction of radiotherapy. And people presenting with spinal cord compression, ureteric obstruction, or pathological fracture need urgent treatment. I'm going to switch and just talk through the guidance on renal cancer, and we will catch up with any questions at the end. So for the renal cancer patients, low priority is CT diagnostic and staging investigations of small renal masses. We're all aware that scans will take place and someone will see a funny looking cyst. They can be safely delayed for over 3 months in order to accurately stage them. And for small renal masses less than 4 centimeters, they can also be delayed. There is nothing very much to be gained by rushing them up into hospital for further tests, particularly at a time when hospitals are struggling doing CT scans for COVID indications. For intermediate things, but we are suggesting that tumours between 4 and 7 centimetres should be staged over the next 6 weeks to 3 months. And for people with clinically advanced or metastatic cancer, they're going to need much more rapid intervention. And we still might need to do renal biopsies to allow systemic therapy for people presenting with symptomatic metastasis. And people presenting with visible hematuria or retention or suspected bowel obstruction or spinal cord compression need to be treated as an emergency, as we always have. And part of the reason we're not going to investigate small renal masses is that we're not going to treat small renal masses. So a T1A renal tumour can be safely watched for up to 6 months. And Bosniak 3 cysts and AMLs can also be monitored. Larger renal tumours in asymptomatic patients can be delayed for a period, but they may need treatment over the next 3 or 4 months. And for people with IVC involvement or much larger tumours, they're going to need treatment much more quickly. And the real only emergency treatment is for those people presenting with active bleeding, and they would probably be best managed with embolization and surgery only if embolization is not available or not successful. For people with metastatic renal cancer, cytoreductive nephrectomy has no real role at this stage, particularly for those with oligometallic disease. And again, people with metastatic disease, where in the past we might have treated that either with surgery or radiofrequency ablation or some other form of focal therapy, the suggestion at this stage is that those patients could be delayed. In non-progressive asymptomatic patients, we should consider surveillance rather than VEGF targeted therapy, but immunodirected therapy might actually be an appropriate thing. And for progressive patients, again, VEGFR receptor generated therapy is the way forward if they are clearly progressing, because we can't delay their treatment indefinitely. For follow-up, low priority is all the non-metastatic low and intermediate risk patients. Their chance of developing recurrence over the 3 to 6 month period is relatively low, and we're unlikely to treat them with new therapy during the pandemic. This will change if the pandemic lasts 9 months or 18 months, and some of these thoughts will need to change. But at the moment, this is the thoughts of the renal panel. For people with high risk renal cell cancer following radical or partial nephrectomy, they will still need follow-up, and probably at the 3 month sort of period. And for asymptomatic metastatic patients who've been on previous medical therapy and have been stopped, then they again would need some form of follow-up at about 3 months. Clearly, those asymptomatic patients currently continuing on systemic treatment will need more regular follow-up. And if people present with symptomatic metastases, they will need investigation as an urgent case. I think it's very important to understand that these guidelines don't replace the original guidebook, and that as well as this, we're balanced on 2 other factors. Across Europe, local capacity is different. The number of infected individuals in the population is different, and how the healthcare system has been able to cope with that is different. And that matters to what you can offer. And local incidence is different. That matters in terms of how risky it is to the patients to undergo treatment. We've already mentioned that asymptomatic individuals who undergo major surgery have a significantly increased risk of succumbing to the disease. And therefore, if the incidence of this is high and it's difficult to identify those individuals, as we've already heard, patients develop COVID probably because they were already infected before they underwent treatment. And that, if that incidence is high, then the chance of that is high, and the death rate might be as high as 20%. And that makes us more careful about what we offer. Any questions, Fred?
Okay, Phil, I'm looking at the questions that are coming in. I see one which you probably already answered about BCG. Should those patients be tested for COVID? I don't think so. Then one sort of question that has come in a few times. What is the risk of rectal examination and transrectal MRI for the one who's doing that? How do you think that is?
So I think the answer is that the infection is in the fecal material. If you try not to swallow the fecal material or rub it in your eye, then the chance is fairly small. If you've got appropriate PPE, then and you are careful about hand washing, then the risk is pretty small.
Okay.
Clearly, if the fecal material gets in an unfortunate place, then that's going to raise the risk of infection.
Yeah, that makes sense, and it also makes sense not to rub the fecal material in your eyes. I think that's a good suggestion. One other question, and that's of course an ethical probably, whether the age of the patient plays a role in prioritizing diagnosis and treatment of malignant disease. We know that older patients have an increased risk from COVID disease. What I see in my hospital that older patients sometimes don't come. They are a little bit afraid. Do you make a difference between younger and older patients in, for example, the choice with renal cell carcinoma or prostate cancer?
So I think that life expectancy rather than age is the important driver. So if we're also aware with the COVID risk that the risk is related to other comorbidities. So if you've got atrial fibrillation, if you're on antihypertensives, if you have obesity, then those things have all been shown to make both a difference to your life expectancy and therefore the benefit that you might get from treating a prostate cancer and your risk of suffering serious outcome from treatment from your COVID. And so I think that we need to be aware that, as with every clinical decision that we do, we have to be mindful that the comorbidity of the patient and their life expectancy will drive what's going on. I don't think it should be age. I'm very keen for it not to be age. There are plenty of 75-year-olds who have a 15-year life expectancy. And in North Liverpool, I would tell you there are a number of 65-year-olds who don't.
Exactly, yeah. So you're looking at biological age, not calendar age.
Yeah.
And are you already, hopefully we will never be forced to do that, are you already making decisions based on, let's say, biological age?
Not yet. So we are only making decisions about investigation. So if you have got a patient with microscopic hematuria and no other concerns, then those at the moment are being encouraged to wait for investigation when the incidence of the COVID is less, because it will make it safer for them to come to hospital. But we're not yet at the stage where people, on the basis of either biological or real age, are being told you can't have treatment because of something. You do have to remember, however, that anaesthetists will make decisions based upon biological age as to whether you can have an ITU bed. And so on that basis, you will see that if you come out of isolation and are unfortunate enough to catch COVID, you may find that the treatment options available to you are limited by the perception of whether you will survive ventilation.
Yeah, makes sense. And like we had, so a lot of IC beds have been occupied by COVID patients. So that, of course, indeed is a risk. If you think that the patient is going to need an IC bed, that's, of course, a different story than if you don't think.
Yes.
One question I think is a good one, because that applies to actually all 4 tumors that we've been talking about. What about the pneumoperitoneum in laparoscopic or robotic surgery? You will lose some air. Do you think that that is a risk factor?
So there, there is no doubt that we have seen virus transmission, other viruses, in air released after a pneumoperitoneum. And as a consequence, if you're going to do laparoscopic surgery, you should keep the pressure as low as possible to try and minimize the amount of air leakage. Yeah. There are devices that are available that will help decrease and maintain a static pressure. And we are careful with PPE in terms of protection for staff members during an operation. There isn't any firm evidence yet that you can get an infection like that. And clearly, if you switch all laparoscopic or minimally invasive surgery across to open surgery, then you expose the patient to another set of risks. So you are more likely to get a chest infection, you are more likely to stay in hospital for longer, you are more likely to have other complications. And so it is a balance, isn't it? We are certainly still doing laparoscopic surgery at the moment.
Okay. One very, depressing question or remark that we may never get past COVID. Well, I think we will. We will have a vaccine, hopefully, but then we will learn from this crisis, I guess, that there are new opportunities, like calling patients by phone for some results and things like that. So even if we go past COVID, I think our way of treating patients and doing follow-up will change a little bit. What do you think about that?
I think that's really important, because at the moment we're all very worried about COVID and how it has changed what we do. But this is also an opportunity to redesign what we do. Some of the things that we've been forced to do, like video consultations, actually work really well. Yeah. And all of a sudden, I think that we don't want to go back to the way it was before there was COVID. We want to be able to say, actually, I can do things better. And when we reinstitute more active practice, as the incidence level drops, we ought to be able to do things smarter. And I think that we will see that there will be benefits. It's difficult to see that at the moment, because we're all seeing all of the problems that are associated with COVID. But when this is done, I think we will notice that we changed the way that we worked for the benefit of patients as a consequence of the trouble that we had to go through.
Further, another question about prostate cancer treatment. You say in your intermediate group that you could consider external beam radiotherapy with androgens, anti-androgens. One question here is that external beam radiotherapy can be immunosuppressive too, and the patient, that's true, has to go to the hospital a lot of times. In my hospital, that's 28 times. What do you think about androgen deprivation therapy, and wait until the crisis is over and then give definitive treatment?
So the question, of course, is, can you have androgen deprivation therapy and then do their operation afterwards? Because surgeons would naturally like to do that, because we worry if we send all of our patients to have radiotherapy. The probable answer, Briganti has produced some data showing that even with high-risk prostate cancer, you can delay for up to a year before you get any evidence of worse outcomes. Now, clearly, patients find it difficult to be told that they've got a cancer and that you could safely delay. But I think that the evidence to date suggests that you could probably delay for 3 or 6 months, particularly for people with intermediate risk disease.
Phil, our daily practice has been for a long time, and we stopped, of course, after the STEMP trials, to first give 6 months of neoadjuvant hormones and then do radiation. So we've been doing that for quite some time, and to my feeling,
I think that I think that works really well if you're going to have radiation, but there is much less, well, there's no evidence to support it for those people who want to have surgery. And so for the patients who are going to have radiation, I think that's right. And that is very much what we have said, is that you should have androgen deprivation for 6 months until such point as it will be safe for you to go to hospital and have your radiotherapy. And I think that's true. The more controversial thing is, could I just give them androgen deprivation and then do their surgery afterwards? And I don't think there's any evidence that androgen deprivation will in any way improve your surgery, and you have given the patient a treatment they didn't really need for 6 months because it made them feel better about the delay. And I think that is much more controversial to do, and we wouldn't support that as an option. So I absolutely agree, if you're going to have radiotherapy, giving you 3 or 6 months worth of neoadjuvant hormones prior to your radiotherapy is an entirely sensible way forward. But giving it just so that I can still do your operation because you're worried about the delay, I don't think that is an appropriate evidence-based way forward.
Yeah, I have to agree with you. We did a trial in the beginning of the 90s in I think in Europe, or only in my country, where we randomized patients between neoadjuvant hormonal therapy and surgery right on. And we thought, the prostate is going to get smaller, so it's easier to operate. But in fact, there was no difference in resection margins, in survival, and whatever. So it might give you the feeling that it's better, but it isn't.
No, it's not.
Now, a few other questions I think you haven't addressed, like, do we like to avoid corticosteroids? I think you already addressed that. The same goes for, do we like to avoid chemotherapy if possible? I also think you already addressed that a little bit. Yes. And the question of my good friend Theo de Rijke, how are these recommendations going to influence future approaches in the guideline? Do you think these recommendations are there to stay, or they're just during the crisis? I think the last.
I think they're just during the crisis. And I already said that, in fact, as this crisis changes, we, in many European countries, have seen probably the first peak of infection. And if we are fortunate and we get suppression, we don't get a second peak, we just then have a low risk of COVID in the population and an effective vaccine, then I think that a lot of this will disappear. So this is very much about the acute episode and how we get through this to move forward to have a new normal, perhaps not quite the same as the old normal, but a new normal.
Yeah, new normal. Yeah, okay. So one thing I think that I see that also a few times, we did address that a little bit, but apparently that is something that that colleagues that are operating find very important. Do you think that every patient should be tested for COVID before surgery? And again, so what we do in my hospital is only if patients have complaints, and we call them all the day before surgery whether they have complaints. If yes, of course, we postpone surgery and do testing. But otherwise, currently, and that has been changing a few times now, we don't test routinely. It's the same for you, Phil?
So we're testing all patients at the moment who are going to have surgery 48 hours beforehand. The evidence for that is a bit sketchy, because remember, if you're an asymptomatic individual, then the test isn't actually very good in terms of picking up whether you've got COVID or not. And that makes life very difficult. So you have a negative test, and that makes everyone happy about progressing. But whether you've really not got COVID, I think it's a bit more difficult to say, isn't it?
Okay. I just got a mail from the organization that we're almost at the end of our discussion time.
Yes.
So
yes.
Maybe we can go to the last slide, Phil. There are some general things for.
There we are.
So we also were asked to address a few general issues, and well, I think we already discussed some of those. One of the major problem is that we are probably not seeing some patients that might we have seen if there was not a crisis. Maybe somebody with hematuria who's not going to the doctor. Patients don't get their PSA test, so we see less patients with a new patient with a higher PSA. So that's probably a group that we will have to see more and more in the second part of this year when the crisis is going to be less. One of the things that we haven't struck. Sorry, yeah.
So the UK has seen a 75% decrease in patients referred to our fast track cancer service.
And that's not only prostate, or?
No, not only prostate, all tumours. I mean, including urological malignancy, but a 75% decrease.
All tumours,
and
yeah.
All tumours, and a 30% decrease in the presentation of stroke. Now, I cannot see a reason why isolation should make any difference to your chance of having a stroke, but clearly people are so scared about what's going on that they are staying home, even with significant life events. And we will certainly see people appear later in the year who have delayed their investigation.
Yeah, we see the same in the Netherlands for cardiac disease. So the cardiologists are seeing much less acute cardiac patients than they used to do. But I think we're almost at the end. Maybe you can just close the session. And for my part, I'd like to thank everybody present, asking questions, and the organization and you, Phil. But the honors is yours to close this.
So thank you very much for tuning in. This will be available online for those people who want to see what trouble we cause. All of these recommendations for this and all other urological conditions are available on the Uroweb website. There is a summary being presented on the European Urology Journal site. So thank you for your interest in this and have a great evening. Bye-bye.